I'd like to introduce our next speaker. It's Dr. Rong He. Rong He is Assistant Professor of Laboratory Medicine and Pathology and a consultant in the Special Coagulation Laboratory and in Hematopathology. She is also co-director of the Molecular Hematology Laboratory. Rong.
How do I advance the... Okay. So my topic is a screening test on working up a bleeding patient. I'll have no disclosures. So the objectives for today is first to provide a brief overview of the physiological hemostasis. Then we're going to talk about the common causes for the congenital and acquired bleeding diathesis. And then I'm going to present a value-based algorithmic approach for the laboratory testing of bleeding disorders. So hemostasis is composed of three phases: the primary, secondary, and tertiary. What's happened in the primary hemostasis as an end result is there is a platelet plug formation, which is the end result from the intricate interplay from platelet, Willebrand Factor, and subendothelium. And it's an initial manifestation of a clot formation. However, this clot is still loose and unstable. The second hemostasis occurs on top of the platelet plug is the coagulation cascade with forming of a fibrin mesh that strengthens and tightens the blood clot to stop bleeding. Tertiary hemostasis is a dissolution of the fibrin clot. It is very important for the limitation of the extent and rate of clot formation to prevent intravascular occlusive thrombus. It's also very important adequate hemostasis have been accomplished to dissolve away the fibrin clot. So more details on primary hemostasis with vascular injury and high shear stress will have endothelial damage with exposure of the subendothelial proteins, importantly the collagen, fibronectin, etc. And the next step is for the platelet to come and adhere to the subendothelium, and this is mediated by Willebrand Factor, which is a multimeric protein, but it has binding domains for both the collagen and for the platelet. So you will bring the two together. The binding of the platelet to the subendothelium collagen through its receptor will result in platelet activation. Signaling transduction occurs inside the platelet, and there will be shape change, degranulation, and the release of endogenous activators. So those released endogenous activators will recruit more platelets to the injury site and activate them, and they will release more endogenous activators. So this is positive feedback loop. The end result is platelet aggregation, and this step is mediated by the fibrinogen binding to the glycoprotein 2B3A on the neighboring platelets. Secondary hemostasis is a coagulation cascade that we commonly refer to. We're all very familiar with the extrinsic pathway and intrinsic pathway. Under physiological condition, the extrinsic pathway is very important. It's a key player in the initiation phase of hemostasis. At the injury site, a small amount of tissue factor is being released, which will go through the extrinsic and common pathway and generate small amount of thrombin. The small amount of thrombin generated then serve as a spark to ignite the truncated intrinsic pathway, which comprises the amplification and the propagation phase of hemostasis, and generate more robust production of thrombin and subsequent fibrin. So as you can see that although APTT evaluates factor 12, whatever is involved in the physiological hemostasis does not include factor 12. So that's why even the APTT is prolonged in a factor 12 deficiency patient, they do not have increased risk of bleeding. So any abnormality occurs in the three phases of hemostasis can result in a bleeding diathesis. And I'm going to focus my talk on the primary and secondary hemostasis today. And they have distinct clinical pathological features. So the primary hemostasis involves platelet, Willebrand factor, and vasculature. And the secondary hemostasis, of course, involves coagulation factors. The bleeding site is distinct. Primary hemostasis usually involves mucocutaneous sites, present with petechia, ecchymosis, menorrhagia, etc., whereas the secondary hemostasis usually involve the deep tissue, such as joint, muscle, CNS, retroperitoneum, and present with hematoma or hemarthrosis. The onset for the primary hemostasis is usually spontaneous and immediate after trauma because they cannot form the initial platelet plug. Whereas for secondary hemostasis, the bleeding is usually delayed after trauma because they can still form the primary platelet plug, although it's not stable. Examples for primary hemostasis, decreased number of platelets, dysfunctional platelets, Willebrand disease, vasculature disorders. For secondary hemostasis, factor deficiencies, inhibitors. So in the workup of a bleeding patient, number one task is history of paramount importance. It will clue you into whether this patient is actually having a true bleeding diathesis or not, because sometimes the complaint is rather nonspecific. And also whether, if yes, whether this is a congenital or acquired condition, and also is this more leaning toward a primary versus a secondary hemostasis problem. And physical examination will also provide additional information on the bleeding pattern. Laboratory test will then come in and help you to confirm or exclude your working diagnosis. So during the history taking, it's very important to inquire about surgical history, but don't forget about the dental procedure. And also nature of bleeding, family history of the bleeding in the patient, but the negative family history does not really rule out a congenital bleeding disorder. Medications that the patient is taking that might increase the bleeding of the patient. We know all the well-documented anticoagulants, but also some antibiotics and herbal medications and nutritional supplements. Those can cause platelet dysfunction. And also concurrent systemic medical problems such as severe liver disease. We know that most of the coagulation factors are made in the hepatocytes. Malabsorption syndrome interfere with vitamin K absorption. Renal failure usually can lead to dysfunctional platelets. So screening test for primary hemostasis. So in a coagulation lab that we usually evaluate the platelet and Willebrand factor, both qualitatively and quantitatively. So for platelets, platelet count and functional assays of PFA 100 and aggregation assay. So one word of caution is that the platelet functional analysis, the PFA 100 and aggregation assay is a live functional test, so it requires live platelets. And so the assay has to be finished within 4 hours of sample collection, so it's usually performed locally. Willebrand factor analysis would include the antigen level, activity, and effect aid activity, because Willebrand factor also serves as chaperone for effect aid in the circulation to prevent it from proteolysis. So this diagram shows the important surface receptor and glycoproteins platelets. Glycoprotein 2B3A is the important fibrinogen receptor on platelet surface. Lack of it will lead to Glanzmann's. And glycoprotein 1A, 2A, and 6 are important collagen receptors. Complex glycoprotein 1B95 is the von Willebrand factor. Lack of it result in Bernard-Soulier syndrome. And there are also multiple G protein coupled receptors, such as ADP receptor and TXA2 receptor, and absence of them will also lead to absent response to the agonist and bleeding diathesis. So a little bit more on PFA100. This is a new automated whole blood primary hemostasis analysis, and in many places it has replaced bleeding test because it's more technically easier to perform and better for standardization. So the machine contains 2 cartridges. One is coated with collagen epinephrine, one is coated with collagen ADP. And in the center of the cartridge, there's an aperture, and whole blood is drawn through this aperture with high velocity. So this mimics a high shear stress induced primary hemostasis. Then the aperture closure time is being measured. So when you see prolongation of the closure time in both cartridges, the possibility include a moderate to severe Willebrand disease, intrinsic platelet dysfunction, moderate to severe thrombocytopenia, decreased hematocrit, and some drug effects such as 2B3A blocker in the patient. However, if the patient is on aspirin or NSAID, usually you only see prolongation in the epi cartridge because the ADP is a stronger agonist. This table shows you the sensitivity of PFA100. It's pretty sensitive for detection of Glanzmann's and Bernard-Soulier. However, its sensitivity for storage disorder is not as good. And also, its sensitivity for the mild Willebrand disease is also not 100%. The other functional testing for platelet is the aggregation assay that measures the ability of the agonist to induce in vitro platelet activation and aggregation. This is low shear stress, this one. And there are 2 platforms that this assay can be performed. It could be performed in a whole blood with impedance technique or with a platelet-rich plasma, and usually the turbidity of the sample is being measured. This table summarizes the expected findings with various platelet disorders, and due to time constraint, I'm not going into details, just going over 2 examples, the Bernard-Soulier or von Willebrand disorder. You can see the response to risocetin is markedly decreased. That's because risocetin is actually an antibiotic that will open up the von Willebrand factor and exposes the platelet binding site for it. So when the patient is having Bernard-Soulier or von Willebrand disease, this interaction is markedly impaired. However, its surface receptor for the other agonists are still intact, so the response to all the other agonists are normal. For Glanzmann's, the abnormality exists in the final step of platelet aggregation with lack of the fibrinogen receptor, so the risocetin response is normal. However, its response to all the other agonists is absent. So switching gears to von Willebrand factor, this is a multimeric protein I measured and I just mentioned, and it contains multiple functional domains in its monomer. Has Fact8 binding domain, platelet glycoprotein 1B binding site, collagen binding site, and also platelet glycoprotein 2B3A binding site. Von Willebrand disease has a prevalence of 1%. However, only 1/10 of them are symptomatic. The female to male ratio is about 2:1. It's categorized into 3 types. Type 1 is partial qualitative deficiency, account for 70% of cases. And type 2 is a qualitative abnormality, about 25% of cases. Type 3 is complete deficiency, less than 5% of cases. So type 1 and type 3 are quantitative abnormality. Type 2 is qualitative. So in type 2, you can see there are 2 subcategories. One is defective platelet adhesion. The other one is defective Fact8 binding. So in type 2A, there is selective deficiency of high molecular weight multimers. In type 2B, the deficiency exists in the platelet binding site. So the von Willebrand factor with type 2B have increased affinity for platelets, so they will bind platelets, activate it, and cause consumption of both. So you will see loss of high molecular weight multimers as well as thrombocytopenia in those patients. Type 2M, normal multimer pattern, however, there's decreased platelet or matrix binding capacity. For type 2N, Normandy, von Willebrand disease, the defect exists in the Factor VIII binding site. So there is marked decrease of Factor VIII level because of von Willebrand factor cannot bind to Factor VIII to protect it from proteolysis in the circulation. However, the platelet adhesion part is still normal. And multimer pattern is also normal. So according to the NHLBI guideline as well as the ASH guideline, the initial screening test for von Willebrand disease would include an antigen level, activity, and Factor VIII activity. Risdiplam has historically been the gold standard for measuring von Willebrand factor activity. However, it's a live assay that requires donor platelets and the patient plasma, and so there's relatively high inter and intra variability of this assay. So we have rigorously validated a latex-based immunoassay that has demonstrated very nice correlation with the risdiplam CoFact assay and superior sensitivity and specificity in differentiating between the type 1 and type 2M von Willebrand disease, and also better sensitivity and specificity in detecting the acquired von Willebrand syndrome. So in our lab, our default VWF activity assay is a latex-based immunoassay. However, with a abnormal antigen level or activity level, the risdiplam CoFact assay is reflexively added. Additional testing for von Willebrand disease workup include a multimer analysis and a RIPA and activity assay that measures the collagen binding activity. So this is a table that summarizes the findings in various types of VWD. Don't have time to go through all of them, and you can read them at your leisure. But I do want to point out that you can see the type 1, we're having the normal multimer pattern. In type 2A, we have loss of high molecular weight multimers. In type 2B, it's consumption, right? Have increased affinity, so consumption of high molecular weight multimers, and also decreased platelet count. Type 2M and 2N is normal pattern, and type 3 is absence of von Willebrand factor. Besides the congenital von Willebrand disease, we also have identified or recent years described multiple causes for acquired von Willebrand syndrome, and autoantibodies, shear stress-induced VWF proteolysis, thrombocytosis-associated proteolysis, aberrant binding to tumor cells, decreased synthesis, etc., and drug-related. So that's it for the primary hemostasis part. And switching gears to the secondary hemostasis screening test, Dr. Nichols just mentioned, we have the APTT that measures the factors starting from factor 12, and the PT measuring the extrinsic pathway starting from factor 7. And we usually add in the thrombin time that helps to exclude or investigate the possibility of a heparin or direct thrombin inhibitor effect in the sample. So the thrombin time and rat place time, we would usually add in the rat place time if the thrombin time is abnormal. The two assays, they have the same substrate and final product. However, the enzyme being used is different. In the thrombin time, thrombin is added. In rat place time, rat place is added. This is a snake venom. The difference is that thrombin is sensitive to heparin and direct thrombin inhibitor inhibition. However, rat place is resistant to heparin or direct thrombin inhibitor effect. So therefore, with a prolonged thrombin time and a normal replace time, that's indicating there's presence of heparin or direct thrombin inhibitor inside the sample. Whereas if both are prolonged, there are multiple causes that can be contributed to: hypofibrinogenemia, dysfibrinogenemia, interference from the elevated fibrin degradation product or paraprotein, the nonspecific interference of the assay, and other spurious anticoagulant artifacts such as an EDTA tube or an underfilled tube. So Dr. Nichols just mentioned the causes of the prolonged clotting time can be categorized into factor deficiency, inhibitors, dysfunctional factors, and pre-analytical artifacts. This is a summary table again for the prevalences of congenital coagulation factor deficiencies, and we can see the most common one is hemophilia A with a prevalence of 1 in 5,000, hemophilia B the second with a prevalence of 1 in 30,000. Hemophilia C is relatively uncommon. However, in the homogeneous population of Ashkenazi Jews, it can be up to 4%. Typical APTT and PT tests have different sensitivities for different factor deficiencies, and Dr. Nichols has mentioned. The level shown here is a ballpark estimation, and it's worth to mention that those sensitivities, they are actually determined by the specific combination of the reagent as well as the testing platform that is being used. And both PT and APTT are not sensitive for factor 13 deficiency, and factor 13 deficiency is analyzed by a specific assay. So in workup of a prolonged PT and APTT, the number one priority, if you have adequate information, is to rule out a pre-analytical artifact, such as if we know the hematocrit is higher than 55%, that can result in relative deficiency, actually lower number of plasma with relative excess of anticoagulant, which can cause falsely prolonged clotting time. So erythrocytosis, or if we know it's a round tube, or there's poor storage or transportation conditions. If we know they are present, then the sample should be rejected, and then the correct sample be collected for repeat testing. If that's normal, then we don't have to do anything further. If we had corrected the pre-analytical artifact and the clotting time is still abnormal, if you have access to clinical history, we should go in and take a look and see whether the patient is receiving any therapeutic anticoagulant, or is the patient have any systemic disorder, such as a liver disorder. Then it's a clinical judgment to decide whether the assay should be performed at this time or not, because if the patient is on anticoagulant, Dr. Nichols just mentioned we do not want those kind of samples. So if the patient is on a factor Xa inhibitor or direct thrombin inhibitor, maybe you can consider redraw the sample after 5 half-lives. So if we have a clean sample that the APTT and PT are prolonged, the next step to perform is, of course, a mixing study. If it cracks, then it's clot factor deficiency, and additional specific factor assays could be added to investigate for specific factor deficiencies. If it's inhibited, that's indicating there's an inhibitor present in the sample, and additional testing can be performed to determine the type of inhibitors, such as whether it's a therapeutic effect, or if this is a specific factor inhibitor, such as factor 8 inhibitor or factor 5 inhibitor, or it's a non-specific factor inhibitor, such as a lupus anticoagulant. So our special coagulation lab is a reference lab, so we do offer a bleeding diathesis panel that we would perform a battery of screening tests up front, and then reflexively adding the additional testing according to what we find from the screening assay in an algorithmic approach. So the assay that are performed up front include APTT, the ones in the blue box, APTT, PT, thrombin time, Willebrand Factor antigen activity, Factor 8 activity, Factor 9, only in male because of the prevalence, fibrinogen, fibrin D-dimer, and Factor 13 screen. So if the APTT is normal, then nothing else needs to be done in this arm. If it's prolonged, then we proceed with a mixing study, and if it's corrected sufficiently, then depending on whether we need further clarification, if yes, then we would add in the factor assays. For PT, the same. If it's normal, nothing needs to be done. If it's abnormal, then we would do the mixing study, and if additional clarification is needed, we would add in the extrinsic pathway factors for further evaluation. Thrombin time, if it's normal, nothing needs to be done. If it's abnormal, then we add in the replace time. This box is grayed out. Those are the additional lupus anticoagulant testing. Clinically, we know that lupus anticoagulant usually gives a thrombosis rather than bleeding diathesis, but it's an important differential to work up a prolonged and inhibited APTT as a reference lab, even though we ask people to fill out the clinical information sheet. Most of the time, we don't get it. So to close the loop, we felt it's prudent to include it in. But if you are offering the test in your own lab, it's your own clinical judgment. And then the same for Willebrand disease workup. If the antigen level is normal, then we look at activity to antigen ratio. If it's normal, nothing needs to be done. If it's low, then we would add the multimers that has increased sensitivity or detecting the acquired Willebrand syndrome. If the antigen level or the activity level is low, then we would add in the resuscitant activity. A low activity, we would also add in the multimers. Normal, there's nothing else to be done. Same for Factor 8. If it's normal, then we stop. If it's abnormal, then we would look at the sample and see whether there's any suspicion for Factor 8 inhibitor. If yes, then we would call the client and ask whether they want inhibitor screening done or not. If yes, then we would proceed, and with the positive screening, we would add in the Bethesda titer. So as you mentioned, we offer this as a limited bleeding panel because we do not include the platelet functional assays because those has to be done within 4 hours. So that's essentially what I have for the screening assays.